Bismillah ar-Rahman ar-Rahim. Welcome back, my colleagues. I would like to launch a series of lectures as regard urology. These lectures for candidates for FRCS, Arab board, European board, and also interesting colleagues. First of all, I would like to begin with prostate cancer, and this is very important topic in urology, and there are conflicting events in the prostate cancer, and usually this topic is confusing for our colleagues. First of all, I will give introduction about prostate cancer. Firstly, prostate cancer, considered in the UK, it is the first or the most common urological. It is the most common cancer. The incidence is 47,000 per year. So it is like epidemics. Okay. So now we have to discuss prostate cancer, and usually prostate cancer is a disease of aging. The most important risk factor is age. Okay. The median age of prostate cancer is about 66 years. It is about 65% of prostate cancer more than 60 years. At the 80 years, mostly 80% of those patients at 80 years are having prostate cancer. So it is a worldwide cancer. So we have to pay attention for this cancer, and we have to discuss it and study it thoroughly. Firstly, whether to screen or not screen this prostate cancer, and does screening is beneficial and can reduce the mortality and reduce the incidence of the prostate cancer or not. According to the Wilson and Younger criteria, whether PSA screening can fulfill the criteria of Younger and Wilson, the answer is no, because the specificity of the PSA is 40%. So it has low specificity. Also, the history of the prostate cancer, it is not well understood because there is long latent period. It may reach more than 13 years. Long latent period. Also, we need invasive maneuvers, because you know that the screening should have maneuvers accepted for patients. We need digital rectal examination and even prostate biopsy. So the screening. So there are two groups. Group with screening and the other group against screening. The groups, the US, the PLCO trial, say that there is no difference. So they not advise the screening. While the UK screening, the most popular study, and you have to know this study, European randomized study for screening of the prostate cancer. This study is very important study. They pay attention to the screening that we need at about 871 screen patient to prevent one death, and we have to treat 27 diseased patients from those screened to prevent one death. In other words, it reduced the mortality by about 4.3 versus, this is the prostate cancer screening versus non-screening, which is 3.6. So according to the ERSPC study, which is a European study, they are in favor with screening. This is in brief. So you are with screening or not with screening. So you have to be ready to say to the examiner that we have PLCO study and European study, and you have to know those studies at least. So what about the PSA? What's the PSA? The PSA, this is the prostate specific antigen. And we have to know that the prostate specific antigen, it is organ specific, not cancer specific. Organ specific, not cancer specific. The PSA is serine protease enzyme. It liquefy the semen, and this is its biological function. The half-life of the PSA is 2 to 3 days. 2 to 3 days. And as the PSA is not specific or specificity is low, so we have to enhance this specificity via PSA kinetics. So one of the most important PSA kinetics is age-related PSA, which is a Sterling study. According to the Sterling age-related, which is the PSA less than 2.5 from 49 to 50, and from 50 to 59 it is about less than 3.5, and from 60 to 65 it is less than 4.5, and from 70 to 79 less than 6.5 nanogram. This is age-related PSA. Age-related PSA. The others is the PSA velocity. PSA velocity means that the increase of the PSA over a certain period. It should be less than 0.75 nanogram per deciliter within 1 year. If it is more than, so it's risky for prostate cancer. And also we have PSA density. We have PSA doubling time. PSA doubling time means the length of the PSA to increase the length of the PSA to be doubled. The length of duration of PSA to be doubled. And this is very important in active surveillance. And necessity for repeat biopsy. But the most important thing of the PSA doubling time is the inactive surveillance. The other parameters, the PSA density, which means total PSA divided by the total prostate volume, which could be calculated via ellipsoid volume formula, which is length, width, height multiplied by 0.52. Okay, and the PSA density should be less than 0.15. If it is more than 0.15, so it's risky for cancer. And there is also subcategory, which is transitional zone PSA density, which means that the PSA divided by the total volume of the transitional zone of the prostate. Also, we have digital rectal examination. We can also increase the specificity of the PSA via also digital rectal examination, and also via prostate cancer antigen 3, which could be assessed via urine, 20 ml of urine post prostate massage. So this is in brief about the PSA, about the prostate cancer, and the PSA and the PSA kinetics, PSA screening. What's important now? According to European guidelines, we have to make screening after counseling of the patient about the fallacy of the PSA. In patient with positive, the patient with at the 40 years, when there is PRCA2 gene positive, so positive family history of breast cancer and prostate cancer, okay? And also those patients at 45 with family history and Afro-Caribbean ethnicity. And also patient at the 50, patient at also at 50, okay? So screening of the patient, this is very important a question. When to screen the patient? So we can screen the patient, men at 50 age, generally, men at 45 years with positive family history of prostate cancer, also Afro-Caribbean descent, or at 40 when the patient carrying PRCA2 gene. This is a very important question in FRCS and in other eras or other tests for the candidate. Then after that, we have to know some studies which are very important, like PCBT study. What's PCBT study? PCBT study, it is prostate cancer prevention trial using finasteride 5 milligram. And they said that finasteride reduce the prostate cancer by 25%, but leads to high grade prostate cancer with incidence of 6.4 in comparison to 5.1 in control group. So in brief, what's PCBT study? It study the finasteride efficacy. It leads to it leads to reduction of prostate cancer by 25%, but unfortunately it is statistically insignificant. But what's significant is that it leads to presence of high-grade prostate cancer in 6.4%, and this is according to the PCBT study. And also we have reduce study. Reduce study also, it studied the dutasteride, which is dual 5-alpha reductase inhibitor 1 and 2. Also the same concept, it leads to reduction of prostate cancer 22%, but with increased incidence of high-grade prostate cancer. Okay, so we have those studies. We have to know the BCBT study, the REDUCE study. Also, we have to know the European randomized study of screening of prostate cancer, and PLCO studies. They are very important studies. This is introduction for prostate cancer, which could be touched in the exam, and it's very important in the exam, especially PSA kinetics. Then after that, I would like to discuss with you important point, which is history of prostate cancer, how to take history from the prostate cancer patient. So first of all, I have to take thorough history from the patient in presence of chaperone. I would like to assess urological symptoms, whether obstructive, storage or voiding symptoms, incontinence, continence, erectile dysfunction, presence red flag signs like hematuria, fever, also bowel function like constipation. Also, I would like by history to assess metastatic symptoms like bone pain, anorexia, weight loss. I would like to assess family history. If the patient have one of his relatives have prostate cancer or not. Why? Because it's very important. If there is one relative, so increase relative risk by 2. If there is 2 relatives, increase risk by 4. If it is 3 relatives, so increase risk by 11. And this is what's termed hereditary prostate cancer in 3 successive generations, or 3 relatives less than 55s, or 2 relatives less than 55 years age. So early onset of prostate cancer. Also ethnicity: African descent, Caribbean descent, Scandinavian, Jews descent. Also drug history. This is as regard history, so I have to assess the urological, the red flag signs, the erectile function, metastatic symptoms, also familial history. I have to assess risk factor for prostate cancer. Okay, after that I take history. Then I would like to make examination of this patient, again in presence of chaperone. I would like to assess the patient generally: body mass index, vital signs, lower limb edema, abdominal examination if there is suprapubic bulge, palatable kidneys, external genitalia. Then I would like to assess digital rectal examination after verbal consent of the patient with lubricant finger, to assess the anal tone, assess volume, consistency, presence of nodule of the prostate. Okay, so also in the history I would like to assess the comorbidities of the patient. If the patient have cardiovascular disease, neurological disease, hypertensive, diabetic. Also in the examination I would like to assess neurological examination, sensory and if there is sensory or motor deficit, the bulbocavernosus reflex. Okay, then after that I would like to, if for example this patient have PSA 5.3, so this patient have 5.3, I would like to repeat this PSA after exclusion of infection. When I repeat the PSA in this patient is 66 years, I repeat the PSA, it was 5.3 nanogram per deciliter. So this is high for this patient. So what shall I do for this patient after history and examination? I would like to proceed for multiparametric MRI. Multiparametric MRI according to the PROMISE study. Why multiparametric MRI? And this is recommended by European guidelines, and according to the PROMISE study, and according also to the precision study, which said that the PROMISE study said that specificity is about 93% in comparison to TRAS and biopsy. So it's recommended for this patient to perform multiparametric MRI. Then after that, and the multiparametric MRI, there are PIRAD scoring. The multiparametric, what's multiparametric MRI? Multiparametric MRI, this is 1.5 or 3 Tesla MRI. It has phases of the T. It has phases of we have T2 weighted image and coefficient apparent image, and diffusion weighted image, and also contrast dynamic enhancement image. So we have at least 3 to 4 phases for this. So we have T2 weighted image, we have weight P diffusion image, we have coefficient apparent image, we have dynamic contrast image. And this assesses the possibility of the prostate cancer according to the PIRAD score. If it is PIRAD 3, this means it's equivocal. PIRAD 4, it's likely prostate cancer. PIRAD 5, it is high likely prostate cancer. After that, this patient is amenable for prostate biopsy, and currently the guidelines of prostate biopsy is European, according to European guidelines, perineal prostate biopsy, not transrectal biopsy, and this is very important. So currently we perform transperineal prostate cancer, not transrectal, because of sepsis, or because perineal is more advantageous because of less infectious events. Then we have to take the biopsy from the prostate to assess the histopathology. Biopsy, like I said, we have many types of biopsy. When I perform, so previously, historical, we take 6 cores, 3 from right and 3 from left lobes of the prostate, but currently we have to take at least 12. So 12 cores, and this is standard. After multiparametric MRI, we have suspicious lesion, hypointense lesion on the right, for example, right lobe of the prostate. We have to take systematic and targeted biopsy. Target biopsy, that we have to take biopsy from this suspicious lesion, and we have also to take systematic biopsies from the prostate. After that, we have to assess the histopathology. What's important in the histopathology to comment is the Gleason score. And what's the Gleason score? Gleason score means architecture of the glands under low power light microscopy. It depends on gland architecture, and shape, spacing, okay? And Gleason score, it is Gleason grade from 1 to 5. Okay, this is the Gleason score. The Gleason grade 1, nodule; grade 2, some difference in the spacing; and grade 3, variability in gland shape and spacing; grade 4, fusion of the glands; and grade 5, sheets. There is no glands like sheets. The Gleason score means the most predominant. It has primary and secondary and tertiary score grades. Primary, it is the most predominant one. Secondary, it is the second most predominant, and we can add tertiary, but in European guidelines we just take primary and secondary grades. And what's the importance of this Gleason grading? Gleason grading is very important in prognosis, in management, okay? It is the most important prognostic parameters in the prostate cancer. Then after that, and also there is what's termed ISUP score, which is International Society of Urological Pathology. It is derived from the Gleason score. When the Gleason score from 2 to 6, it is ISUP grade 1 or score 1. Also 3 plus 4 score 2, 4 plus 3 score 3, and also 8, which is 4 plus 4, or 3 plus 5, or 5 plus 3, it is 4, and from 9 to 10 it is 5, and this is the ISUP and it's very important in risk stratification of biochemical recurrence, post-radical prostatectomy or post-radio therapy. Then after that, we have to know the clinical staging of the prostate cancer. If it is known during resection and less than of 5% of the resected tissues affected, so it is T1A. If it is more than 5% of resected tissue, so it is T1P. If it is known by according to the PSA and we take biopsy, it is T1C. So clinically it is not palpable, not visible by image. So it's not visible, not palpable by image or by examination. This is T1. T2A means that the tumor affect less than one loop, less than half of loop. T2B, more than half of loop or affecting whole loop. T2C, bilateral, so bilateral. T3C means extracapsular extension. T3B, seminal vesicle involvement, and T4 affecting adjacent structures like sphincter, rectum, etc. And then N, if it is N1, means nodal involvement, usually obturator and external iliac lymph nodes, and M1A means non-regional lymph nodes, M1B bone metastasis, M1C visceral metastasis. Okay, then after that, so we have now take history, examination, radiological investigation, biopsy of the prostate. Now, what's important in management? The most important thing is risk stratification. We have to make risk stratification of the prostate of the prostate cancer. According to the European guidelines, we have to stratify prostate cancer into low, intermediate, and high risk prostate cancer. Low prostate cancer, it means that the PSA less than 10 and the Gleason score is 6, and the clinical stage is T2A or less. Okay, and intermediate, PSA from 10 to 20, Gleason score 7, and the clinical stage is T2B. And high risk prostate cancer, Gleason score, PSA more than 20, Gleason score more than 7, and the clinical stage is T2C and T3, okay, and T3, T4, okay. In NICE guidelines, it's different, but we have to be strict to the European guidelines, like I said before. So risk stratification is very important. As regard lymph node involvement, there is nomogram. The most important is Parton's nomogram, which predict lymph node, and extracapsular extension, okay, and seminal vesicle involvement. Okay, this is Parton's table. Okay, and in the other sessions we will discuss the management of the prostate cancer according to risk stratification.